All right, so we can get rolling here. I think there'll still be some people rolling in as we go. Thanks everyone for joining us in the physical therapist portion of the discussion forums for the International Consortium of Manual Therapies. My name is Rick Weatherald. I'm a physical therapist. I practice in an orthopedic outpatient clinic in North Carolina now. I've actually practiced in 5 different states. I finished my doctor of physical therapy in 2013 at Texas State University, and I was board certified in orthopedics in 2018. I enjoy all aspects of physical therapy. I don't consider myself specifically a manual therapist, but I was interested in collaborating with this group to kind of help build my knowledge and kind of contribute from a physical therapist standpoint. So with me to help contribute tonight is Paul Metler. Paul, how you doing?
Hi, great. I hope everybody's going to enjoy our meeting this evening. I'm Paul Metler. I just give you a little bit of background on myself. Graduated in '81 with my bachelor's degree. In 2006, I got my transitional doctorate from Rosalind Franklin University School of Medicine. And first 3 years of practice, I worked in an outpatient, inpatient setting. Next 6 years, I was in an outpatient sports medicine clinic. And then for 30 years, I had my own private practice. And we developed a kind of a wellness model where we did physical therapy, massage, personal training, nutrition, fitness. We had 1,800 members. I sold the practice last year, and we are Dr. Jeff Schroeder, a fellow therapist that's worked with me for 20 years, has helped me develop a continuing ed program that we got certified through the Illinois Physical Therapy Association. It's 6 online and 8 hands-on credit hours. So we're excited about that. I've done some research with high-frequency shear-wave ultrasound and done some presentations at the Fascia Research Congress. And I joined the ICMT about 7 months ago. And I wanted to join it because I want to advance the productive culture for interprofessional collaboration and advancement of science and practice of manual therapies. And I've been impressed with the vision, the focus of the international interprofessional teamwork, and the commitment and the sense of humor, and most importantly, the leadership to make this happen. And I would highly recommend and encourage anyone interested in this mission to investigate becoming a part of the ICMT. And we look forward to sharing with you what we've been working on so you can evaluate and provide your comments and critique to improve what has been done to date. So thank you, Rick.
Thanks, Paul. And then we also have, we'll be working in the background, Brian Degenhart, and Brian is the Assistant Vice President for the Osteopathic Research at A.T. Still University and the Director of the A.T. Still Research Institute. Some of you PTs might recognize A.T. Still University for their physical therapy school that they have in Arizona, and they also have, or maybe more well known for their osteopathic medical school, both in Arizona and in Missouri. Brian is also the chair of the conference planning committee for the ICMT. So for everything that Paul and I have been involved with, Brian is heading everything up. We also have G. Franklin with us. G is the chair of the business plan committee for the ICMT, and he's also the media coordinator for the ICMT. So all technical things, all the questions when I press the wrong button on the Zoom call and all this stuff, G's there to slap me on the wrist and and tell me how to fix it. So they won't be contributing much unless there are questions that are pertinent to them to answer. So this is a meeting style, not a webinar style. So everybody can talk and contribute. So with that, if you guys can, it looks like everybody I think be mindful and keep your microphones muted unless you have a question. If you do have a question, if you guys are familiar with Zoom, if you're not, if you look down on the bottom of your screen right now, there's a little button that says reactions, and you can raise your hand. We can't see everybody's screen here, so if you raise your hand, that'll cue one of us to kind of call you in, and then you can unmute yourself and ask a question. And we do encourage that. We put this as a meeting style, not a webinar style, because I want this to be a discussion forum, not just me talking at everyone. So looks like everyone's muted now. So what is the ICMT, the International Consortium of Manual Therapies? It's a group of PTs, chiropractors, DOs, structural integration practitioners, and massage therapists, and some other professions with manual therapies. And they focus on key topics fundamental to building a productive culture for collaboration to advance the science and practice of manual therapies. So I took that verbatim just off the website. So what does that mean? We are looking at getting everyone that performs manual therapy on someone who has pain or a movement dysfunction, or anything we'd be doing with manual therapy, and looking at, hey, from each profession's mindset, what are we doing? What do we think we're doing? What are the things that we do that are different and the same from other professions? And then how can we use that collaboration to guide research and then look at what research has been done in other fields? So for example, us as physical therapists, we should more or less be up to speed on the manual therapy research and other research that's in our field. But how can we grow from being able to take what chiropractors have done or osteopaths have done and be able to understand and comprehend their practice and then learn from it? And then also, how can we contribute to say, like, hey, osteopaths, chiropractors, whoever, or basic scientists, they're a big involvement here as well. If you're going to do biology, biomechanics, tissue level research, whatever the research you're doing, if we can guide it this way, this is a way that we can all understand it, not just the chiros or not just the DOs, so that everybody can understand that better. So that's the basic goal, is to basically get everybody come together in a way that we can share the research and help guide the research moving forward. So the inaugural conference is in May. It's a virtual conference. It's May 4th through June 3rd. We'll cover more of that at the end of this meeting. So, and we'll cover the way it's going to go. It's going to be a fun little thing. It's not just Zoom meetings, which can get a little old. So, so in the ICMT, we've had 3 different working groups so far, working groups 1 and 2. So the working group 1 is defining the manual therapy procedures. So what that is each profession is going to come in and say, hey, here's the things that we do. Here's the terms that we use if I put my hands on somebody and I do this, or push a joint in that direction, whether it's a joint or a soft tissue, here's what I'm doing. Here's what I think I'm doing to the tissue. Here's what the technique is called. This is the mechanism I think I'm affecting, and here's the outcome I think it's going to do. Topic number 2 is to look at the physiological theories. Why do I think, as a physical therapist, when I do a grade 5 mobilization or manipulation or an HVLA technique, why do I think that's affecting the patient? What ways do I think that's affecting them? And then we basically compare and contrast that. And that's been some quite interesting discussion. We meet every other week with a couple people from each one of these professions. And it's actually a lot of fun to hear, the ways people perceive. If I'm taking a joint and I'm moving it this way, as a physical therapist, I think of this, and then the chiropractors say, well, I'm thinking of it this way, and the osteopaths will say, oh yeah, no, I think of this, and we consider that. And so it's actually been some really, really cool discussion that we move on with, and it kind of will make you think a little bit different about the way you're thinking as a physical therapist about your techniques. So, and then topic 3, which Paul and I are not a part of on purpose, to keep us separate from this, they are going to characterize the current research on all this stuff. So we say, here's what we think we're doing. And then topic 3 is going to say, yeah, here's what the research says you're doing. And then then that kind of defines the implications for, the mechanisms and the actions that they're doing. So the goal of this meeting, we're going to share a link in the comments section here. G, if you can share that right now. We're going to share a link to a Google Drive, that has some of the documents that we've been working on. And this is documents specific to the physical therapists and the physical therapy profession side of things. So we want to review we'll just do a quick review on like manual therapy terminologies, the terms that we're using. And then we're going to go over like different techniques. And you guys, and these are kind of base level techniques. So this is not going to be somewhere everyone's going to learn some great new technique that I learned from the osteopaths. This is just what we as physical therapists do. Everything that I talk about should make sense to you. And the purpose of what we're here for, I'm going to describe to you guys a technique, and I'm going to say, this is what Paul and I have kind of come up with to represent the entire practice and profession of physical therapy. And we're going to put it forward to the other professions. So Paul and I are obviously only 2 people. So we want input from everybody. Yeah, that technique sounds right. This doesn't sound right. Hey, this other technique might be also doing this thing on a physiological level. We kind of want to hear that. And it doesn't need to be real deep stuff. It's just the way you're thinking as a physical therapist. I want to try to submit these these documents to topic group 3 and then for use in the greater ICMT. And I want those to represent the physical therapy profession as a whole, not just what Paul and I have said. So we try to understand it as broadly as possible and use references that are broadly available. But we may have missed the mark in some places, and we're glad to hear input on that. So when we're going over this, you guys can use the raise hand. You can also type something in the comment section. So we'll be looking for that too. Now, I'll go over in a minute. The link that you guys just got shared, that is something that you can actually go in and comment on the documents. You can't edit the documents. That's Paul and I's job. But you can comment on something. So if you didn't raise your hand and speak up today, but you think, there might be something here that I want to add, you can actually go in and write some comments that we can read on that document real time. If you guys know how Google Drive works, you type something and it's automatically saved, and we can see, and everyone can see it. So if you, Cameron, if you type something in the comment section and you say, hey, I think this might be better worded this way, then Bob, you can jump in and say, yeah, I agree with that, or that sounds right. So, and we can do that here, or you guys type that in the comment sections of the document. So if you guys want to, you can kind of minimize the Zoom meeting so you don't have to look at my face anymore, and pull that drive up. I'm gonna screen share as well in case you don't have that link pulled up. And we'll do that right now. All right, so G, can you give me a head nod that I'm screen sharing properly right now? Okay, cool. All right, so first we're going to go a quick overview. If you guys go to I think it's going to be the first folder here, technique descriptions. Yeah, it may be a different order in your folder, but go to the technique descriptions, and then Paul's just going to go over real quick this terminology for physical therapist document. So Paul, take it away here.
Yeah, so these are not, obviously the only manual therapy terms that we think are important, but we just did our best to come up with some of the key terminology that we feel are used in the physical therapy manual profession. And I'm just going to read the names of the terminology for the physical therapy techniques that we've come up with, and just get some I don't want to read the whole thing because it just gets to be too complicated and detailed. So in general, we've got neurodynamics, creep, hysteresis, shear, tension, viscoelasticity, compression, torsion, nerve gliding, nerve flossing, entrapment, traction, fibrosis, hypoxia, edema, axioplasmic flow, ischemia, hypomobility and hypermobility, distraction, soft tissue mobilization, soft tissue manipulation, joint manipulation, joint mobilization, hyperirritability, and densification. And what we did was we put links to these terms so that you can actually, click on the link and see where they came from. And when the group 3 gets this terminology, they'll be able to use these links to check on things. So
okay, so that,
yeah.
Oh, sorry, go ahead, Paul.
So I didn't know if anyone had any comments on that they would like to entertain at this time.
Yeah, and that may be something that everyone, as they read over the document, see what's what they want to contribute there. So Jason, you have a question? You can unmute yourself.
Hey, thanks. Am I coming through okay?
Yep, we can hear you.
Yeah.
Hey, thanks. Jason Silvernail here. So I'm not sure why we're using free online dictionary references to define biomechanical terms. Shouldn't we have a biomechanical resource for that? Does that make sense? Some of these things I don't think we need to make up definitions on our side. Is that like these like things like axoplasmic flow and edema? Could you scroll up a little? Do you mind?
Yeah, sure. Sorry.
Thanks.
Sure.
Like I think that we should have scientific biomechanical and physiological references, in my view, for these things and in lieu of Wikipedia. And I feel like on some of these things, when it comes to like mobilization or manipulation, I think it's likely that there's going to be a range of definitions between the schools of thought that are present in PT that are sometimes informed by some legislative conflicts that we've had in the past, that I think it might make it difficult for us to generate one definition of that sort of thing. And I guess I wonder what the group's thoughts are of that, or Rick or Paul, if you want to comment. Thanks for hearing me out.
Yeah, thanks for the comment and the question. That's absolutely a quite valid source. So these terms here are, we'll go over the actual templates there in just a minute, and you'll see there's not going to be any Wikipedia references in there, but we pulled some stuff from say like Physiopedia. And this is something that when we're in the cases where we're not using specific say like research or textbook references, like the things that we would be used to, like we would get dinged if in PT school or in a residency we cited Wikipedia on something for sure. The goal here is to say what PTs as a whole do, like you were saying, and there's going to be a bunch of schools of thought, and that's why we want this contribution. So that's why sometimes we just link to something that says like, hey, here's a general overview of what these terms are. This list that we're looking at right now is just terms of the types of techniques that I should say the types of approaches that we're going to use within the techniques that we're going to cover in just a second. So that is, like I said, that's absolutely a valid comment that like, hey, we're using Wikipedia, but like I said, it's not, our job is not to validate this with the quality of research and everything. It's just meant to convey, hey, here's the verbiage that we use in the way we're thinking. And so if a dictionary description of that goes and can be adapted or applies to what we're thinking, then, that'll be a quick link that we can put in there. So Paul, do you agree with that? Or you got anything to add?
Yeah, I mean, if Jason has some particular references or things that we could use to, go back and look through this, I'd be happy to do that. I just didn't have that available to me.
Yeah. Thanks, guys. I'm assuming good faith here. I'm not trying to throw a wrench in you or be difficult. Please don't misunderstand. I just feel like if we're going to put scientific words up there, we ought to have scientific references for them. And I know you guys are smart and have access to that kind of stuff. And with the right time and attention, we can find a common reference that's appropriate and that kind of stuff. And I think Jeff Schroeder's telling us that nomenclature is definitely a challenge. And I agree with Jeff that there might be a little bit more, it might be hard to get some good consensus on that. Even smart people of good faith who mean well, I think, are likely going to end up disagreeing on a lot of those points. And so I think that's a valid perspective as well. Thanks again.
Yeah,
thanks for sharing.
Thank you. Yeah, and that professional and courteous disagreement is kind of what we're encouraging here, because this is what we want, right? So somebody needs to look at this and go, hey, we should do this. And I do agree with that. That's a good thought. Bob, do you have a question?
Thanks, appreciate it. I think that last discussion was great. I wanted to talk about the joint manipulation, joint mobilization, and for years, going back to when we formed the APTA Manipulation Task Force, we worked really hard at coming up with a definition, and which is really a continuous definition for mobilization and manipulation, and that's, you know, present in the guide. And that was a negotiated and agreed upon consensus between APTA, AOMT, and initially orthopedic section, and now AOPT, the Academy of Orthopedic PT. And so I believe we really have a good, strong working definition of that right now. And so to separate those two out, I think is not consistent with where the profession is right now. Mm-hmm. So I just wanted to share that with where I think we are as a profession, based on my perspective, at least. So thank you.
Okay. Yeah, and thank you for your contribution. And in a minute here, when we start going through the actual templates for the mobilization stuff, I'm going to go through the each technique template, and you'll see the way I have it broken up into the different grades. And that may be, and I'm not sure if you looked ahead on the documents and that was what you were commenting over. We'll be going over that in just a minute. So you might have actually some really, definitely some pertinent input on where we stand. Should we be breaking these up? Paul and I, again, as the PT contribution, when we were putting forth our ideas of mobilization and comparing it to what a chiropractor would think of or an osteopath would think of, that's where we decided to break it into and we at this point we can move ahead right now. That was actually a good segue. So we can go back to this drive here, and then let's just since I was going to go with instrument assisted stuff first, but Bob, since you brought it up, let's go to the grade 1 and 2 MOBs, the mobilization grade 1, 2. And so you'll see that I have them broken up into grade 1, 2 document, a grade 3, 4 document, and a grade 5 document. And that was something that we did based on the fact that we had the other professions hadn't heard this grading theory at all. And that was actually, we almost spent like an entire hour-and-a-half meeting on just that. What are the definitions of, a joint, the available joint play and the joint space that we're working through. So we decided to break it up in this way based on the goals of, say, a grade 1 or grade 2 mobilization being similar, and a grade 3 and 4 being similar, and then a grade 5 having its own goals. And then the definitions would look different for other professions. So I don't need to read through this whole document, but the gist of it is that the amplitude of movement within the range of the joint, the grading system, we should all, as PTs, I think we'll probably all be quite familiar with this, so I don't need to review that. But given that the goal is basically diminishing nociceptive stimuli, so decreasing pain of a joint, neutralizing pressure and moving synovial fluid around, that given that the grade 1 and 2 have those goals, that was the idea, that we had to put this into their own document. You'll see the 3 and 4 and 5 will have their own as well. So Paul, do you have anything to add to that? I know you're kind of more the soft tissue guy, but do you have anything you want to add here?
No, I don't. Again, Rick and I are clinicians. We're not in the academic field and things like that. So we didn't have a lot of other eyes looking at this, and this is why we are presenting this, because we do want to provide a good product on the PT side, and that's it's important that you're here to voice your opinions.
Yep. So and we can, Bob, you might, it sound like you had some pretty good input on this. Do you want me to move on to the 3 and 4 and 5, or do we want to discuss this right now? Do you have some specific input you'd like to do on this, or should we go through the whole, all the joint mobilization documents?
Yeah, thanks. I think it's, just keep going. Let's see.
Okay. I didn't mean to put you on the spot there, but I want to keep the discussion going. So we'll go on to the 3 and 4. Here it is right here. So again, we broke them up into 1 and 2 for the lower amplitude, not joint end range pain relief goals. And then the 3 and 4, we're looking at larger amplitude or small amplitude that's going to run into the end of the available joint range. You'll see in here in the joint mobilization documents, it will talk about the idea of closed pack versus open pack and the way that we're going to, take up the slack in those ranges based on which grade we're doing. And then we have some examples of how these are performed. We used a spinal example here. I know PTs would also think of this as peripheral joints as well. Use a spinal example just because our interface that we're working with, they kind of more readily will pick up on this, but we're happy to put in some a shoulder, a knee, or a hip example as well. So and here's our proposed Yes.
Hey, this is Dan Rohn. I'm sorry, I missed the first
sure.
part of it. I'm traveling, and I just want to make sure. So I apologize if you covered this already, but I mean, this sounds like one specific, like this sounds very, Maitlandish based, but that, there's people that do different types of, at least in PT, that's what this sounds like, but we do have different types of approaches to manual therapy. And so it sounds like we're describing a very specific approach. And so I don't know what the purpose is. Are we is the goal that you're trying to break down all the different approaches or schools of thought behind this, or because I'm just worried that if we're trying to describe manual therapy behind one specific approach, we have PTs, even just in our academy alone, that there's different focuses and different different schools of thought, and so they're all going to be a little bit different. So I guess I'm sorry if I missed the whole purpose and goal here of breaking these down. I just want to make sure we're heading down the right track.
No, and your question actually that brings up a good point, but you have a valid question. So we will probably actively, or I should say we're actively avoiding anything to say like, oh, this is the, a Maitland approach, or this is going to be, a McKinsey type approach or anything. We're avoiding any, named approaches. Now, this grading system will have its own school, segmented school of thought coming with it. And this is, like I said, this is the whole reason we're here, is like, is there another way we should be able to, is there another way we should word this to say, if I'm doing a joint mobilization, what is my goal? And it is independent of this grading system. And that's the way we're going to convey what we do as physical therapists to other professions. So yeah, if there's probably going to be shades of the way I was taught in PT school. So, and then the way I was taught in my rotations. And then, Paul will bring his own shades in, and then, you guys bringing this up and saying like, hey, this is not, the way I'm thinking of it. That's good input. So yeah, we do want to avoid that. And you'll see in some of the other, when we talk about some of the instrument assisted stuff, we try to stay away from like a Graston school of thought, or, in a specific brand of something. So, does that answer your question?
Sorry, I was on mute. Yeah, I think so. I think I feel like a lot of these things we probably have in some of our documents as an academy. We put a lot of time putting into this. And so I just, maybe we can share that at the end, just to make sure we're not reinventing the wheel. There's been a lot of work, with IFOMT, I think, as Bob said before, and then within our own academy, to describe a lot of these mechanisms. And I know we've got some documents and stuff, so it might be worthwhile to look at that.
Okay. Yeah, I agree. And since we're talking about it right now, in one of just in any one of the places, any one of these documents where it's appropriate, just so we have easy access to it, can you drop those links in there, or just a link and say, here's this, you can even just say, here's the stuff I was talking about, and I'll know, we don't have to rewrite the whole conversation. So I'll know what we're talking about there. So.
Sounds good.
And then, so we can, again, go back to that, and then we go back to the grade 5, which, again, we're just using, we just talk about some examples of how this technique's performed. And we do that so other professions can say like, oh yeah, that looks like when I do in this case, a rib manipulation, or a thrust manipulation. So we have a definition of the technique here. the high velocity thrust with the small amplitude, which that vernacular is pretty common amongst the professions that use that. And then here's actually some of the spot where I wanted some input on this, because this can obviously get into such a huge, we could make tons and tons of documents on what's the proposed mechanism of action of an HVLA technique. And so I just wrote in here just a quick, kind of overview to talk about change in afferent signaling, whether it's decreasing nociception, changing tonicity, changing muscle tone, things like that. And this is where I kind of want to open it up to people. What other ways can we think of or expand on this that doesn't try to reinvent the wheel and show all of the research that we have or that we know of, but just say, hey, let's add this component to these mechanisms of action. What can you guys add into that, if anyone can?
This is almost a bit of the holy grail. I know we're still looking for mechanisms, but I guess there's proposed mechanisms. We just don't know for sure how much, or how those vary. We're still not sure.
And so this is going to be a spot where, we might pull up some of the different views that we have. So what I didn't put in here was anything to do with spinal alignment, SI alignment, anything of that nature. And maybe guys can speak to this, because that's something that I view as a profession that we're kind of trying to leave that behind. And I know that we have plenty of clinicians that still will at least consider that when they're, doing manual therapy techniques or assessing a patient, diagnosing a patient. I just left the alignment part, anything like that, out of all the proposed mechanism there. Does everyone agree with that, or does someone have a disagreement with that we need to consider that? And also, if you don't want to speak, oh yeah, go ahead, Cameron.
I would just say, I think what we're seeing in the discussion is that the work's been done already elsewhere, and that if the reach out was just to AOMs, as representing to IFOMs, APTA, looking for those, as Jason described, the high fidelity resources with definitions that are already somewhat agreed to, I think you could move on to that next phase of speaking into the shared discussions, the osteopathic, chiropractic, and other realms. And so I would look to those already public-facing documents in such ways, like the manipulation education manual hasn't been updated, or the glossary that others have referenced. Because otherwise, you're sort of, this is restarting a journey that's already been completed in many areas, what I sense, for this profession.
Yeah.
That's why I just want to be careful too, that we're not doing is sort of reinventing the wheel.
Yep. And like I said, that's the whole reason we're reaching out here. And now you guys are more familiar with the documents and manipulation guides probably than I am. Do you feel like this would be a good representation of the physical therapy profession as a whole? I mean, obviously, if we're talking about the fellows that have been through all the training, they're going to understand it at a very high level and have a very good understanding of that. Do we feel that's the way that everybody, that the majority of the physical therapy profession would say, yep, that's what we're doing? Does that jive with what we're thinking?
I don't know, but that's like two different questions. One, I mean, having an organization that represents manual therapy, here and internationally, and coming up with our guidance, that's one thing. Having all of the 200,000 PTs that we have in the country agree. I think that's like a really tall order. I don't know if we'll ever get there, and maybe that's why we, intentionally with some areas are a little bit looser and probably allow for a little bit of a little bandwidth, because there is so much diversity out there. It's really hard to say, hey, you've got to come on board with our definition a little bit. I just think that's going to be really challenging to do to some degree. Like, you can boil it down to some degree.
Yeah.
But to get everybody on board and say, this is what manual therapy means, which I think is why we push for manual therapy as an approach, a clinical reasoning approach. It's not just the techniques. If you come and understand the approach, and it's less about what's the technique that I'm doing, and it's about the whole package that you put together and how you treat the patient. And I think our professional organizations probably try to push that mantra a little bit more, so that it's less about, am I doing this specific technique, but the framework that I'm using that technique in as I see the patient, and the clinical reasoning that goes into it. And so when we as an academy and organization are trying to make a point with our residencies and fellowships, I think it probably aligns more with that than the specific, a focus on a specific techniques. It's more of an approach. That makes sense.
Yeah. Yeah. And you spoke to earlier the fact that we've never tried to come to every PT, 200,000 PTs. We all think this. And I can tell you in interacting with the other professionals, the other clinicians from other fields, that is, as you can guess, that's not an issue that's specific to our field. We probably know the ins and outs of our own issues and our own, differences more so than we would between two different chiropractors looking at the same thing. But that's something that's definitely not specific to us. So, and that's good input to be looking into these. Probably placing maybe a little more emphasis on the documents that the AAOMPT and the other organizations have put out. So, Paul, do you want to take up the STM document?
Yeah, you want to pull that up there, Rick?
I sure can.
So what we've been doing is breaking these out into osseous and non-osseous types of technique. And we use the general category of soft tissue mobilization for one of them. And, this can encompass a lot of different types of treatment, like myofascial release, cross-friction massage, acupressure, you name it. There's a lot of different things. But in general, the definition of the technique is it's a manual technique used to reduce pain, relax muscles, improve circulation, increase range of motion, restore strength and function. It also is used to treat stiff tissue and adhesions, which may form within soft tissue as a result of trauma, surgery, immobilization, or repetitive strain. Soft tissue mobilization is applied very specifically for the treatment of musculoskeletal, lymphatic, or neurologic effects. So that's what we came to as a definition for soft tissue mobilization. Again, it's a big area. So, and then the example of how the technique is performed, we said that there's a variety of techniques that can create mechanical stresses. And basically the main stresses are compression, tension, shear, torsion, and bending stresses. And for example, therapists may apply a gentle sustained pressure and stretch the affected tissue with and without joint movement using the palms of the hands. So then there's the proposed mechanisms of action. And again, it's difficult to say what this all should be, but we came up with stiff myofascial tissues under a sustained load will elongate secondarily to physiologic biomechanic tissue processes of the viscoelastic properties of the ECM and collagen. And this is referred to as creep and hysteresis. So that's basically what we decided to put together for soft tissue mobilization. So if anyone wants to make comments on that in the comment Google Doc, that we would appreciate that. Anybody?
As far as I know, these have been defined in the description of advanced specialty practice at AOMT and potentially in a couple of other professional ones too. I don't have that in front of me to copy paste into the Google Doc, but my sense is, and I think what I'm hearing in the comments and in the conversation is that this is actually good news. That a lot of the standardization that you're looking for, I think has already kind of been done. And it may be just a question of, and I think that's really good news for having to worry less about going over things that we've done. Some of this stuff is probably sort of done and dusted and presented, and there is a good consensus version of what this looks like. And I don't know if it's as tightly focused as sort of an executive summary that Brian is asking for, but it at least represents our professional society's views on this, which I think is going to be to a greater fidelity than what, like what I might say, for example, the world according to Silvernail, I think we've got a lot of this stuff done already in AOMT,
you're right,
IFOMT, at APTA that I think would really be helpful. And I think it would speed this work along pretty good. And I think that's good news. I just don't happen to have it in front of me to copy paste in, but Dan and others are providing and links and I think Sorcha dropped a link to the iFont as well. Thanks.
Thanks, Jason. I couldn't agree more. I think that's a lot of the work has been done. It's just we didn't know where to go to get it.
Well, you're asking the right folks now. We can pull together a lot of those things, and I think that will make this whole process much smoother for you. Like the good news is I don't think we have to do maybe as much work as we might think to pull this together. I don't know how easy it would be to distill that into a 5 to 10 minute interprofessional conference and say, here I am, unelected person representing everything, representing all 200,000 of my professional colleagues. Yeah. I don't know if I would sign myself up for that, much less anybody else. But like at least we could have a starting point on vetted professional documents, and that will, I think, are pretty open about some of the uncertainties and mechanisms is probably an area where there's a lot of uncertainty. And Dan just dropped a link to some of the experts we've got in our field who are documenting in that vein.
Well, that's terrific. This is what we need. Thank you. So, Rick, are you there?
Did you want to move on to the MET?
Yeah, document? Let's go on to the muscle energy technique.
And I think we can go through these pretty quickly. I think now because what they're talking about, these documents that we can source. I do think that'll probably, like they said, speed up some of this, and it's up to us to kind of distill this down to this little one-page thing, and you voiced the challenge, directly, is that we have, it's kind of up to the two of us, I guess, to speak for the whole profession, which is why I want to sit here and kind of almost get grilled on this and say like, hey, that's not what we think, or here's a better way to describe it. So yeah, these are exactly the kinds of comments we're looking for. So.
Right. And like some of these, we're not even sure if they're, if we should classify them in the manual therapy realm of what we do. So we need that kind of feedback as well. Of course, soft tissue mobilization is definitely a manual therapy hands-on technique. But like the next one is muscle energy technique. And as you know, that has a lot of different means of being done as well. And basically it's, you know, the post-isometric relaxation, we came up with that one, and then the post-facilitation stretch technique, and they're both based on the auto inhibition or reciprocal inhibition effects on the soft tissue. So, you know, the proposed mechanism, you can kind of read what we put together as far as how they're performed. I don't think I need to go through that. The proposed mechanisms, of course, were the autogenic, which is, yeah, I believe that's connected with the post-facilitation stretch technique, signaling of the Golgi tendon organ at the musculotendon junction of affected muscles, causing stretch reflex, which inhibits the targeted muscle from contracting further and allowing increased stretch. And then the reciprocal mechanism is contraction of the antagonist to the target muscle, which causes inhibition of the targeted muscle based on the antagonist-agonist concept. So both of them are related to the autogenic reciprocal neural system, and it's a transient type effect. So we think this is more of a neurophysiological type approach or effect. So that's what I have on that muscle energy technique. And then another one that we were questioning, you know, is strain counter strain. That's a technique used in the physical therapy field, and you know, it's basically involves trying to take a painful muscle and create a relaxation effect by putting it in a shortened position and holding it there for like 90 seconds. And then you feel the tender point or the trigger point area, and you want to feel that relax. And you repeat that process a few times. So you can kind of, again, read what we have put together for strain counter strain, and the proposed mechanisms of action is basically involves the Golgi tendon organ associated with muscle holding and resulting in the tender point to reset, and it returns to normal function. So that's the theory anyway. So that's what I had put together for strain counter strain. And again, not, you know, it's a hands-on technique. And I would assume it should be included in this category, but we're open to comments and certainly analysis of that.
I think the challenge with some of this research is like even trigger points are a bit of a contentious subject because it is a theory, and some argue that there is, and some argue that there isn't any evidence to show that there is trigger points. You know, there's a lot that has been published both ways, and nothing that has really been able to validate that theory of a trigger point, even though you know, we might see it in the clinic. And so I think that sort of happened a lot of times with our original mechanistic research was, you know, we had these theories about things, and then it might work for other reasons that we're not aware of.
Right.
But it's hard then to argue some of these things when it's hard to show proof that there is such thing as a trigger point. So, I mean, I'm not saying one way or the other, but I know that that's not an assumption. That I know that there's a lot of people that, you know, have arguments about whether trigger points is even a real thing. And so it's hard then, if you can't fully validate a construct, to then get behind it and say, this is the mechanism of action.
Yes. And in this instance, I'm not sure they're talking about trigger points. I think it's a tender point, which.
Oh, I gotcha.
Yeah, there is a bit of difference there, but at least in my mind. But
Well,
Right.
Paul, I think Dan's points are overall are that a lot of the theoretical mechanisms here, both the ones here and like a lot of Chidow's work too, those theoretical mechanisms they're pretty speculative, and I'm not sure how valuable it is for us to go over them if we can't adjudicate their accuracy one way or another. Now Chidow might be right about this stuff, but he might not be also. And I don't think there's any way for us to know whether he's correct or not. And so once we're at that stage, I wonder, like, what's the value of us discussing a lot of this stuff if we can't adjudicate it to a level of fidelity one way or another? Does that make sense?
I think I thank you for your comment. I think that what we're trying to do is just put these proposals together for group 3. And group 3 is the scientific community, and they're the ones who will evaluate, whether these proposed mechanisms of action actually hold water. I think that we have to move to that level to try to figure out, are these proposed mechanisms of action, are they really happening? And I think that's where our group 3 scientific community comes in. And so we're just presenting this information to them, and then they have to decide what to do with it. So that's, I don't know if that helps answer your question or concern, but that's what this whole process is about, is trying to put together, good information, and as we can, the best information and understanding that we can of the techniques, definitions, how, give them some idea of how you perform the technique, and then the proposed mechanism of action.
So Paul,
yes.
Paul, to talk into that, because there's been a dry needling advisory group for APTA for quite a while now, and I've served on that a few times. And that has proposed mechanisms underpinning trigger points and the application of technique. That already exists. It's in the white paper on dry needling that was put together. It's also in the recent competencies for dry needling. They're all APTA public facing. These documents can be obtained. And so really what I'm hearing is maybe the task here is more just to gather the available resources, present them as the current proposed mechanisms that are in the majority agreed to by the PT profession, but are not represented as being the absolute be all and end all. And then you let the scientific community chew on it. And I think that's very purposeful. And
yes,
it's also,
that's what this is all about. That's right.
They're heavily referenced. And if you link the resource and just had a summary of it, it would simplify things. And then because the resource is there, boy, you're not going to have it as much as maybe strain, counterstrain, and some of the what hasn't been a more focused consideration the last couple of decades. Manual manipulative therapy has been a profession. There's a lot of resources. Dry needling has been. There's a lot of resources. Soft tissue realm, not as much. I think in that particular area, it's going to be a little bit more theoretical, and that'd be proposed mechanisms that haven't really been brought together in one group. There is no overarching academy around soft tissue as much in our profession as there is around these other topics.
And I would agree with that. And I would love your assistance with this. That would be terrific, because that is exactly what we need. We need to get this information to the scientific community so they can evaluate whether or not what we're saying we're doing with our hands or with tools or whatever we're doing, we're actually doing, or what are we doing? So we can try to do an analysis of what actually happens.
Brian, did you want to jump in here?
I would. Thank you, Rick. So for those of us who have attended various NIH meetings over the last 10, 15 years in the area of manual therapies, a lot of times there has been a great divide in the ability of clinicians to communicate with the basic scientists and back and forth. We have developed certainly some clear in our own minds, some clear rationale for what we do and what we think, why it works, but it doesn't get translated well to the basic scientists, and we're not around to really help to figure out how to best study these types of issues as well. And so this is a starting point to try to get us across professions being able to talk about the same things, because there's only so many different ways we can push, pull, and twist tissues, and be able to have basic scientists in that conversation to be able to, once again, help our clinical experience, help to shape the direction of their research, and for them to then use terminology that we understand to help us apply the outcomes of their research into clinical practice.
Thank you, Brian. That was very well said, and that's exactly what we're trying to move toward.
Paul, I might jump off of our order here just a little bit, because Cameron was bringing up the trigger point, and that's where we can kind of segue into the dry needling thing, kind of skip over and segue. And I won't take too much time to go over this document, but that, just like Cameron was talking about, where they talk about the proposed mechanism of action of the dry needling. You know, whether we're looking for the twitch response, or we're looking for the twitch response or not, and it kind of hinges on, is there an actual thing as a trigger point, and looking at what our PT consensus is on that, to see what are we thinking that we're affecting when we're sticking that needle in tissue. So, you guys can go over and look at the proposed mechanism here, and then we can, I'll also be able to include the information from that white paper as well. I've been taking notes as we've been going along, and also we've got notes that you guys are dropping links in that are going to be very valuable to us. So like I said, without going through this whole document, is there anything that anybody would like to expand on the dry needling? Whether we're, should we include the twitch response? Should we not include the twitch response part? Talking about the trigger point, don't talk about the trigger point. So.
No, I mean, now that I understand the background, that's a fair question. We don't know, some people swear by the twitch response, some say it doesn't matter, some swear by the trigger point, some say it doesn't matter. So in my mind, if the NIH is looking to fund research and the scientists are looking, those are the things that we have debates about. So if the bench scientists want to get in there and help figure out whether there really is a trigger point and whether you can address the trigger point, it actually leads to first potential mechanisms, theoretical mechanisms that they can measure, and then in clinical practice it actually leads to reduced pain. We don't have to agree on that definition, but that's a point of contention. And so usually the research, I'm a clinical scientist, I do a lot of research, but you focus on the things that are unknown, that people have contentions about, that people disagree on, to see if you can shed more light on it. And I think there's probably a lot more disagreement on the mechanisms. And so maybe just listing out not how everybody agrees that a technique should be performed, because there's lots of disagreement on how techniques should be performed, but list those disagreements and say, yeah, these are the things that we don't know for sure. And these are the areas that could use some more research to figure out, if we do want to know the mechanisms, this is what they could focus on. That might be a more, more valid approach. And I get that at these NIH meetings, everyone has, differences, but maybe we need to focus on the differences and, figure out which hypotheses are right and which ones are not right.
Yeah, and that's some great input to say, should I, if we're going to write a proposed mechanism action section, should I reword that to say, here's one school of thought, here's another? And that would be a quite valid approach, I think, to maybe more accurately, capture, because we're going to say physical therapy, but with something like dry needling, the other professions that that use that, they may use the same terms and may not as us, but there's probably that same debate there too. But, you know, we're not worrying about that. We're worrying about what we're talking about. But to say a consensus from physical therapy that talking about the discord in there, and putting that actually out there in the document would, I think that I agree with that might be helpful, and it's something I hadn't considered yet, a different way to word that. So.
Yeah, because I mean, I think getting to consensus, we've been trying to get to consensus on things for decades, and you can only get so far on consensus.
Yeah.
Because there's just lots of variability on just practice in general. So you get consensus so far, and then you just have diverging views. And if the bench scientists want to explore that, I think that's great. Let's list out all the different varying views and have them. I mean, that, in my opinion, that seems like, you know, maybe that generates some questions right there. And we don't have to come to an agreement or a consensus across the board, but we could just put a list of things that we're not really sure about that they could that they could look at in more, you know, in more detail.
Yeah. Okay.
Rick,
Go ahead.
yeah, I certainly agree with that. I mean, I think that's very, very important. And I definitely would support that.
Yeah, I agree with that. That looks like something that we might go back and look through those, and I'm sure we're going to end up with some comments on these documents that we'll sift through and apply here. But taking a step back and say, here's the discussion that might more accurately capture our, or say maybe even the disagreements that might more accurately capture our profession's view on this particular technique. What, you know, and we've got dry needling pulled up right here. You know, trigger point or not, twitch response or not, you know, that may be something that would help us along, I think, and I like that thought.
Yeah, and I think it'd be really helpful for those who are inclined is to actually, you know, in your comment section, put in some of those proposed alternative mechanisms of action, so that Rick and I don't have to try to reason this all out, because we're not there. I mean, we don't have that capability. So if you can help assist in that effort, that would be huge.
Yeah. So, okay, so next we'll this is the end of the documents. There's a couple other documents on there on some nerve glides, and I think some instrument assisted work that we can, you know, you guys can look at and contribute in the same way. I want to close by looking at the way the ICMT conference is going to work. So like I said, it's from early May to early June. I think May 4th to June 3rd. I'm not looking at the dates right now, but basically May to June, and it's 2-day Friday, Saturday on the first weekend of May, and then the third weekend of May. And the actual gathering area is done at a place called Gathertown, which should be shared right now. And so this is an area that it's almost like I thought of an old Zelda game, where so my character here is going to walk around, and when the conference is actually live, this area will be available for the entire month. And when, you know, on the Friday and Saturday, when there's a lot of people present, everybody else's avatar will show up, and, you know, you'll be able to see everybody and then go to the different presentations. You can see there's the conferences, the breakout rooms for the professions. You see G here is actually his avatar's here. So if you just walk up to somebody, you'd actually start connecting with them as well. And then there'll be some things, some posters and some aspects, some information that's always available here, not just when the Friday, Saturday presentations are actually live and going on. So this is somewhere that, you know, you can go in your free time and look around and read the different things that we have. And then there's the live discussion forums on the Friday, Saturdays, on the first and third weekends. Brian, you can jump in and correct me, or G, you can also jump in and correct me on anything if I misspoke or add anything to this as well, to the way we're utilizing this for the conference.
You're doing good.
Yeah, Rick, did you mention that this will be available then for 30 days post-conference, which is
Yeah. Okay.
really,
Yeah. That's
I think that's an amazing feature, and you'll be able to go in and, you know, move around all the different rooms and revisit them and, you know, interact with others that are in there. So I think it's a really neat feature.
Brian.
Let's
Oh,
Yeah,
yeah.
so if
Sorry.
I could just clarify a couple of things. So the conference site will become active on May 4th. And for May 4th and May 5th, we'll be giving tours and instructions so that people get very comfortable with the space and how to, you know, utilize the tools to optimize engagement, learning, and so forth. So we have two-day blocks, the 6th and 7th and the 20th and 21st, where we have explicitly defined programming. We have keynote speakers that include Dr. Arndt Nielsen from Denmark, who's one of the leading researchers in musculoskeletal medicine in the field of pain, and Helene Langevin from NIH. And what we're hoping is that, like conversations we had this evening talking about, well, you know, we're not just talking about techniques, we're talking about actually our approach to, you know, the patient. We're hoping that we will be able to provide space for people to have those types of conversations throughout the month. So one example is I've talked with Cameron about potentially doing one on the history of manual therapies and having people from different professions give backgrounds about, you know, their history within, you know, a more spontaneous program. All of the programs are going to be recorded, so you can go back at any time and watch them again. So unlike another conference where you get to listen to it once and all of a sudden within 2 hours, you're wondering what you heard, you knew something was really important there, but to translate that back to practice is not very easy. This environment gives you a whole month from May 4th in order to watch and think about, engage in discussions with people, to really, you know, try to build relationships, build collaborative directions, create understanding that will hopefully move this overall field into a whole new direction. So that's what this is laid out for. So Jeff, do you want to add on to that? No, we're good. Okay.
That's exactly what I was about to do.
Okay.
Thanks, Brian and G. All right, so that kind of concludes everything. This interaction is exactly what we had hoped for in this forum, this particular meeting tonight. We got exactly the information we were looking for. I really appreciate everyone's discussion. Probably maybe even more information than we expected, but that's great. I'd rather have way too much than not enough. So, Sorcha, did you have a question?
I just have a quick question. You mentioned the third group as being sort of the scientific community. Is that a group of individuals that have already been targeted and asked to do that, or what's the process in sort of the setup for how to move this forward?
Brian can actually speak to that because that is a group that's already going, but Brian can speak to that.
Oh, okay. Thanks, Rick.
Yep.
So we have done an extensive literature search. We've divided that up into different groups. We had some PT PhDs who were participating early on, but when COVID struck, it really caused a lot of people to have to pull back on their commitments. So if you are interested in participating in Working Group 3, please let me know, and we might be able to get you connected to help with that process.
Thanks, Brian. That's really helpful. It just struck me as everybody was talking that there's a lot of knowledgeable people in the room that might be able to provide some insight who are sort of maybe comfortable and relatively familiar with a lot of the literature already. So it's not to be, again, reinventing wheels that don't need work.
Thank you. So once again, anyone, please reach out to Rick, Paul, or myself if you have interest in getting more involved, and we will, find a way to, help bring you into the process.
And as we're talking about this, I just realized that the document that has our contact info is not made live right now. So I think our contact info is on the ICMT website. That's ICMTconference.org. I'll put a document on that drive that you guys have the link to right now. And that link will remain public. So you can go there afterwards, after this meeting, I think continuously. I'll make sure that document's public there so that you guys can have our contact info. If you want, the ICMT is on Instagram, YouTube, and Facebook. So if you're into the social media thing, you can follow there. Also, if you can't find my email, you can reach out to me on Facebook or Instagram. I don't use those in a professional sense, but I'm happy to respond to messages there professionally. So yeah, thank you guys, everybody, for coming out tonight. I really appreciate the input that you guys had, and it's going to be very valuable for us. We actually got a lot to dig into here. So Paul and I have a lot on our plate now. So thank you. And that's all. You guys have a good night.
Thank you, Rick.
Thank you. Bye.
Thanks
Thank
for
you
putting
guys.
this
Have a good
together.
night.
Thank you, guys.
Thanks, everybody.
Thanks, guys. This was really interesting.